afternoon. Can everybody hear me? I certainly am glad to be able to present this talk with my dear colleague and friend, Dr. Burroughs-Ray. And we name this, a clinician's prescription because oftentimes I think the prescriptions for wellness have been done by people that are not clinicians. And sometimes the interventions prioritized don't reflect the fact that burnout is not something that you can pizza party your way out of, or certainly any amount of healthcare heroes t-shirts or anything like that will change. So when wellness matters, utilizing organizational resources, we'll come to why we say organizational in just a second. As good educators, we want to have good learning objectives. So we want to identify what are those contributions to physician burnout and what are the barriers to wellness, because it's not really just a matter of getting to know burnout, but also some degree of wellness and hopefully even professional fulfillment. What are the system, organizational, and individual practices to reduce the impact of burnout? And then again, what are those organizational kind of well-being things that we can do? We have no relevant financial disclosures for the content of this presentation. And so let's talk scope of physician burnout and what exactly that means. When we talk about burnout, it is actually a pretty complex phenomenon. I like to think of things in terms of Venn diagrams, and it is an intersection of three Venn diagrams. And it is that intersection of emotional exhaustion, depersonalization, and then success of work-life integration. And they kind of go in their own sense of balance. Certainly when there is more depersonalization, where there is more emotional exhaustion, without a concomitant increase in success of work-life balance, work-life integration, we expect that we will see more burnout. And as you all have experienced along with us from 2020 on, we have seen that burnout has reached unprecedented levels. In 2022, there was a paper by Dr. West and colleagues, looking at what were the reported prevalence of burnout among practicing US physicians. And they used a very common burnout inventory. It's called the MASLAC burnout inventory. And it particularly looks at things such as emotional exhaustion and depersonalization. And we've really seen since 2020 a rapid increase in the amount of emotional exhaustion and the amount of depersonalization. And we'll talk about later how those things can look like in everyday routine clinical practice. But I don't think that that surprises anyone with just what has gone on during the COVID pandemic. And even now, as we begin to talk about endemicity, when emotional exhaustion and when depersonalization is high, it is no surprise that personal accomplishment lags behind. You don't have the mental bandwidth to really think about trying to achieve other things. You're just simply trying to survive at work. And it also, I think, highlights something that we don't like to say a lot, but I think it is true. Burnout is an occupational hazard. And if it's an occupational hazard, then there has to be occupational changes or structural changes in the occupation to actually mitigate the impact of burnout. Otherwise, we're putting Band-Aids on it. Now, that survey showed that 63% of practicing physicians at least reported one symptom of burnout. And I would argue that that even in and of itself may be underreported. There's probably Unfortunately, we do see in this survey and others that women physicians and those that are otherwise underrepresented in medicine were twice as likely to experience burnout. And unfortunately, this spans the spectrum of training. So it's not just practicing physicians, it's residents, it's medical students. Unfortunately, when we say burnout is an occupational hazard, it's permeating all throughout the training system, which is why I believe we need a clinician's prescription for what to do about it. And while I hate making a business case for burnout, it costs over $1 billion, or sorry, $1 million to replace one physician. Now, if you think about 63% are reporting at least one symptom of burnout, we have certainly seen that some have chosen in the midst of the pandemic to either significantly reduce their practice or go completely out of practice. That's not sustainable for the health. And I wish I could just say it's the economics that matter. This slide has a lot of different papers linked to it, certainly about errors and things. The one that probably speaks most to me is this one here. And that's the association of racial bias with reported burnout. Not only is it an occupational hazard, but it can directly cause harm to our patients. In that, resident physicians that reported higher levels of burnout, whether that's emotional exhaustion, depersonalization, actually reported also having more racial bias in the care of their patients. Now, I don't want to overstate that too much, but just simply to say, if we know these things and know that burnout has this much of an impact, then I think we all can feel, hey, what can we do to impact this? What can we do to change this? It's not just about numbers. It's not just about the feeling of it. It is literally, it can impact who we take care of day in and day out. Again, I mentioned this inventory earlier. It's very common in the literature. And it just goes to show that, you know, it can feel hard when having to answer these questions so many times about what's going on and why is there so much burnout. But I always like to say I'm an internist first, and most internists know that before we can get the assessment and plan, we have to have a good history and we have to know where things are coming. So I'm gonna give you a little small breakout and we'll walk around a little bit just for a couple of minutes. What does physician burnout look like where you practice? And how do you identify physicians experiencing burnout? So we'll take just a couple of minutes and then I'll invite just 2 or 3 people to share thoughts, but just pair with the person next to you, a so-called turn to your neighbor, if you will. We'll have a little bit of a reflection exercise here. Take about 1 more minute. All right, let's all come back together.
Clap once if you can hear me. Clap twice if you can hear me.
2, check 1, 2.
Oh, those childhood games come right back,
Check,
don't they?
check 1, 2.
All right, Dr. Jackson.
Yes. So
Check.
I just wanted to hear just a couple of responses. We'll do 2. I know that there are multiple responses out there, but just we want to stay on track with our time. So just anybody wants to share a quick reflection? that. Yes, right there in the back.
Hi. Burnout for me led me to leaving my job the day that I came in. That wasn't my plan. For background, I was the associate medical director in an FQHC in the desert in southeastern California. And I'd been there for like 12 years and I felt not heard, not valued. I was given responsibilities without the tools and was still being held accountable. And then the last straw that morning was I was asking the clinical manager of the clinic something. She got upset. She touched me at my hand to get out of the room. So at first I was flabbergasted. Then I asked her, "Did you just push me?" She turned around and in front of like the whole staff yelled at me, "Why are you making things up, Dr. Khan?" So I finished my patient load that morning. Like I retreated to my office, cried for half an hour, finished my patient, and I had a so-called, not a contract, but an at-will agreement. So I sent my email, sorry to resign. And 2 hours later, HR called me to pick up my final check. So that's how much they valued me. I felt better. I started losing weight after that event, and I feel so much better now. Thank you for listening.
I appreciate you sharing that reflection. And first, I want to say that it really illustrates perfectly some of the issues when we talk about burnout, the isolation, the gaslighting, and then how institutions just move on. There's a so-called Simone's maxims where they talk about the institution will not love you back, that it can be sometimes a major issue when we talk about burnout.
Just one more sentence, like tell my colleagues and students, you are replaceable at work. You are not replaceable as a daughter, a son, as a mother, a father.
Absolutely. Absolutely.
I actually had a similar situation occur in a free clinic setting that I had served for 14 years, but my specific observation is that when I started practicing medicine, most of the practices were physician managed and run. And then when they started becoming administrator and financially managed and run, we went from having 30 minutes and a transcriptionist and a medical assistant and an RN and a specialist who made all appointments and a billing person and all of those things. And by the time I retired, thank the Lord, in 2022, I no longer had a transcriptionist. I did my own billing. I did my own ordering of today's tests and future tests. I did my own, of course, editing of my transcription. I had half of a CMA and 1/5 of an RN. And I had 15 minutes to see a very complicated elderly internal medicine patient instead of the 30 minutes that I had when I started practicing. And how can you not burn out when you're doing 5 people's jobs?
Absolutely. And one thing we'll talk about a lot today is the importance of resources, organizationally speaking, and some of the data behind that, because they view it sometimes from a lens of efficiency or cutting costs when it might actually be adding costs down the road, even though we can see that as clinicians. It's not always seen by those that are not clinically facing or don't deal with the same challenges we do.
I guess I maybe I'm a little bit fortunate to some extent because I'm a surgeon. At least when you're in the OR, that's your one domain where you're still kind of the boss. The rest of the world, you're not, but at least when you do it. And I did stuff that I really PAs or NPs couldn't really help out much with it. The more senior level residents or fellows could. I was doing spine surgery. So it's not everybody could walk in there and start plucking away. But I look back when I started my residency, my chief had a very busy practice and he did total joints. and he did 6 a week, 2 twice a week, and that was considered a horribly busy practice. He got reimbursed in actual dollars more than guys doing total joints are today. And our expenses go up. Either you have to get rid of people who try and do stuff like we just heard, but you're trying to make ends meet, basically run a practice. And it's very frustrating. And that's the burnout. The patients, I find the patients are still great. I mean, there's always gonna be a couple knuckleheads you got to deal with, but in general, the patients are great. The need to kind of plow through people, and I always would tell my residents, if you let people talk, and you got to control it a little, they're going to tell you what's wrong with you, again, with orthopedics, but you don't have the time to do it because you're too busy typing, WNL, we never looked on the computer screen, doing, filling out the forms. And that's really what it's gotten to. I think most of us, especially people my age, we went to medicine to actually interact with people. It was an interactive experience. It's totally losing it. And being a surgeon, I had time where I didn't really have to interact, but I actually enjoyed seeing patients. And it's hard.
It's all about getting back to the primacy of the patient-physician relationship, and all of these other things that take away from that are usually the biggest contributors to burnout. If you ask most physicians, if not that, it's literally what is not allowing me to talk to my patients. We're going to move on just for the sake of time, just because I want to make sure Dr. Burroughs-Ray has her time.
Wonderful. Well, thank you all for sharing. I will apologize for my voice. My 9-month-old daughter is sharing everything she gets from daycare, and today it's laryngitis. So now we're going to talk about now what? Well, we've identified burnout the problem. You guys have shared your stories, so we're experiencing it. This isn't anything new, but what do we do about it? So let's take a shift. We're going to shift from burnout and actually talk about well-being and wellness. And I would argue this is how we prevent burnout from occurring in the first place. Dr. Jackson, as my wonderful outpatient compatriot, he would argue that prevention is what he prefers. On the inpatient side, I like treating. That's why you're coming to me. I'm taking care of business. All right, let's talk about wellness. The National Academy of Medicine defines wellness as a state of personal fulfillment and engagement that leads to joy and passion, and ultimately a connection to why one went to the healthcare field in the first place. Some of you guys have already shared that, reminding yourself that you went into becoming a physician because you wanted to talk to people. If you think about that personal statement you wrote to get into medical school, I'm quite sure you didn't talk about wanting to document everything that your patient had and doing all this billing. You knew nothing of that. You wanted to talk to people and help them become better. So when I start talking about wellness, usually people's eyes tend to glaze over. And this is what I imagine goes on in their head when I mention the word wellness. So I will just describe to you guys what this is. This is a clip from a sitcom, and it's two individuals. You see one person coming in with a boom box, like, yo, yo, yo. And then someone comes in, they're like, you know what today is? Treat yourself day. And then they sing, treat yourself. I can't really sing. And they kind of celebrate like treat yourself day. And so they talk about how treat yourself day is when you take a day out of the year where you indulge in all the things you like, whether it's fine, whether it's good, cupcakes, mimosa, whatever it may be. It's treat yourself day. And so oftentimes when people think about wellness, they think that it's something you just do once. You're like, I'm going to work really, really hard all year, and then I'm going to take a vacation to Disney, and that's my reward. But in reality, we should be focusing and integrating wellness into our daily activities. It should be intentional, and it shouldn't be something that we have to work 364 days for in order to be able to enjoy it. So let's talk about achieving well-being as a physician. As Dr. Jackson has already alluded to, burnout is a workplace phenomenon. And what is happening is that you're having a misalignment of your values versus the values of that specific organization. And when that misalignment occurs, that's when you have strain, and that's what leads to burnout. So what we're trying to do is actually align these two values. So great, we talked about burnout, we talked about wellness, and that's important for physicians, but how do you do it? It's not that easy, right? Here are some obstacles that have been identified when we talk about physician burnout, and I just want to highlight a few of these in the next couple of slides. So the first one is dehumanization. As we've talked about, for those that have been in practice longer than I have, noticing the change in the trend of the amount of time that you have to speak with your patients. We start to not view our patients as people when we spend less time with them. And when they suddenly become diagnoses because we have to bill, we have to code, we have to acknowledge and keep track of all the things that we're doing. Recognizing hospital policies as well as protocols that can erode at your physician autonomy, where suddenly you're not able to use your clinical acumen or your clinical judgment because the protocol requires this next step to occur, whether or not you agree with it. And then similarly, having to prioritize documentation over patient interactions. As was mentioned before, where our residents and fellows now are focused on documenting everything in the EMR, as opposed to actually turning around and talking to their patients, because they've been taught that in order for you to be a good physician, you have to leave by this time. And there's only so much time during the day. So instead of talking to patients, you spend that time documenting because we have work hour restrictions. You have to go home and stop work. And then also loss of autonomy when we think about scheduling. For those that may be in the outpatient setting where your schedule is set months in advance, and you may not have the ability to integrate or to involve those aspects that are important to you, whether it's soccer games or other family events. And next, let's talk about the environment that we're working in. So just thinking about the professional environment. As a physician in the United States of America, you must have a medical license for the state you're practicing in. Oftentimes, those medical licensing boards want you to have maintenance of certification. And that comes with a board exam once you pass it. And about every 5 to 10 years, a group of rowdy physicians gets together and kind of says, why am I paying money to say that I still know this information? Is this really the best way for me to demonstrate that I am practicing evidence-based medicine? For me to do this maintenance of certification exam? And then thinking about departmental. So whether you're at an institution, a hospital, a clinic setting, who's in that leadership role? Are they prioritizing wellness? Because oftentimes if they're not, who's going to talk about it? And then just our daily activities. You're a member of a healthcare team. So we're constantly interacting with ancillary staff, nursing, respiratory therapists, or other physicians. So we have to be able to make sure those relationships are strong and we're having good communication. Otherwise, it makes it difficult for us to do our job. We've all heard the term note wars, where instead of physicians or clinicians having a conversation over the phone, they're just documenting back and forth, and usually patient care suffers as a result. And then the last thing I want to mention is resources, just because it's something that I would argue is probably top of mind, because we're like, this is cool, but how do I get funding for this? Who is going to invest in it? And we know that mental health resources are not abundant. We can't even get them for our patients. So how are we able to ensure that physicians, who I would argue are a group that's under special stress with the difficult situations they encounter, do we have the resources to help us navigate that? We don't have curricula that we actually engage in that's targeted to us to address our specific well-being needs. And then also thinking about credentialing. Every time you get a new job as a physician, they send you this nice packet, or now it's a DocuSign that you flip through for like an hour, or you have to attest to all of these things. And often those credentialing questions include, have you had to seek mental health care? And now there's a shift to say, well, if we're encouraging people to seek mental health care, we should penalize them or make them feel that it's punitive. If we're then going to ask them to disclose that they previously received mental health care resources, well, that has nothing to do with what they're currently doing right now. So kind of shifting from acute mental health care versus like, yes, I received mental health care and now I'm doing mental health. So we'll take some more time right now, do another small group breakout. And I want you guys to once again pair up and reflect on what are some of the barriers to physician wellness in your current work environment, and then start to think about what things could change or would be helpful if they change to actually address those. So we'll take a couple of minutes like we did before, and then we'll come back together. Bring it back to the large group. Clap once if you can hear me. Dr. Van knows. Clap twice. Clap 3 times. There we go. I got more than 2 people that time. All right. Would anyone like to share from your discussion you had with, yeah, Dr. Van. Sorry, Dr. Van.
Use that microphone.
So our group is made up of trainees, and as a group, we decided that documentation, of course, is playing a large role in increasing burnout through the burden, limited time, can't see your patients. One of the best things transition from intern year to supervisor is that you have more time to spend with your patients, because now, unfortunately, the interns are doing the work and the documentation. But as an aspiring informaticist, I do want to say there is hope for us. There are a lot of people working on ambient AI listening to help you generate your HPI. There are a lot of hospitals implementing systems to use generative AI to pre-design some messages.
Here, try this one.
And I think that in the future, a lot of it will be driven by, the ability to code patients appropriately for their complexity. So I think that's going to be one of the driving factors for integrating AI into the EMR. So I do want to remain hopeful for that, but we do recognize that documentation has played a large role in increasing the amount of burnout that we feel as trainees as well.
Thank you for bringing that up, Dr. Zhang. I briefly tiptoed in the era at one of our hospitals where we had paper charts. And some physicians will argue that the switch to electronic health records may have been the demise of physician wellness. And that because we have switched to electronic health records, now there is this premium where your notes are now used for billing. Where previously your notes were used for documentation and for the next clinician to know what was going on. So hopefully with more technology, maybe it will save us from the EHR conundrum we currently exist. Wonderful. Thank you, Dr. Zhang. Well, we will continue to move in the interest of time, but thank you guys. All right, so how do we promote physician wellness in the clinical setting? So we've kind of illustrated that there are all these obstacles and there are all these things you can do, and honestly, it can feel a bit overwhelming. We're asking you as the individual to start to think about how could you improve physician wellness. So we're gonna kind of talk about this from 3 different levels. This is how I like to think about wellness and well-being. So you have a systemic level, which is at the very top. You then have organizational, so department, your institution, your clinical practice, and then you as the individual. So before we delve into this, I wanted to share this quote that I think is pretty impactful for what we're going to discuss next. This is from Thomas Schlick, and it says, physicians in 2018, this is even before the COVID pandemic, are the proverbial canary in the coal mine. While the canary may be sick, it is the mind that is toxic. Caring for the sick canary is compassionate, but likely futile, until there is more fresh air in the mind. And I want you to keep that in mind as we continue this conversation, because we often talk about the canary in the coal mine, and the focus is the canary in the coal mine. But just because you see the more resilient canary into the coal mine, the outcome will not be different. You don't
Particularly when physicians, I would argue, are probably some of the most resilient in terms of data when we track on inventories. We're actually the most resilient. So it kind of suggests to me like we already come into the coal mine pretty resilient, and it's everything else that's going on in the coal mine, like the lack of oxygen and things, that is the problem, not necessarily our individual resilience.
So thank you, Dr. Jackson. That me finding that quote may have been inspired by words you've said to me many times before. Let's start off on the system level. So this is Dr. Vivek Murthy. He is our U.S. Surgeon General, and he released an advisory on health worker burnout and well-being at the beginning of the pandemic. And so whenever the U.S. Surgeon General, whenever they present an advisory, what it's doing is it's calling the stakeholders, the insurers, the training institutions, the government to come to the table and say, hey, we need to make a difference, because if we don't change something, this will become a public health emergency. So in this advisory, there are a few things that he talks about. One is protecting the health, safety, and well-being of all healthcare workers, eliminating punitive policies for those that are seeking mental health or substance abuse help, and then also reducing administrative and other workplace burdens and prioritizing health worker well-being. This is a beautiful diagram that puts all those things together. So I would like to take it one step low, because I would argue the U.S. Surgeon General, these are like pretty important people, and I will probably never meet him in my lifetime. And the policies he makes will probably not directly affect me. So what's something that can be a little bit closer than the U.S. Surgeon General? So we're going to look at more of a state level with local advocacy. Dr. Jackson and I are both a member of the Clinician Medical Association, which is an advocacy nonprofit organization whose primary goal is to promote the health of clinicians. And that is through promoting policies that allow physicians to provide the best health care to them. And so they, House of Delegates this past spring, passed a resolution to actually create a physician wellness committee. So highlighting that this is so important that this organization needs to create a committee specifically designed to address that need. In addition, there's a legislative committee that already exists, and we gather in the spring to talk about our goals as far as legislation we want to propose to our legislators during that upcoming session. And physician wellness is one of those things that we're going to be focusing on. Primarily credentialing, once again, and highlighting that we should not be penalizing those that seek mental health care, if we're encouraging not only our patients, but also our colleagues to seek help if they need it. And so removing those questions from credentialing so that people will actually seek the care that they need. So we're going to take one step down and now talk about the organizational level. So thinking more about where you practice, those who practice. The National Academy of Medicine is one of 3 academies that primarily focus on sciences, medicine, as well as engineering. And their goal is to provide objective data on what it is that we can do to improve those specific committees. And in this instance, we're looking at the Action Collaborative on Physician Wellbeing and Resilience. So what they did is they came up with these 6 domains. So they were essentially like, this is a problem. Here are 6 domains that we can focus on that have evidence-based interventions that can actually improve physician well-being. Organizational commitment, so having your organization prioritize physician wellness, having leaders in that role, whether it's a well-being champion or a CFO, conducting a workplace assessment to see what physician burnout exists, thinking about policies, and working on workplace efficiency, something that's already come up in some of our discussions. So let's actually look at some studies that specifically identify organizational level interventions that have been proven to improve physician well-being. So the first is an intervention to promote physician well-being, job satisfaction, and professionalism. So what they did is they provided 1 hour paid for these individuals to remove clinical duties, given compensation for their time, and every 2 weeks they met in physician-led discussion groups to talk about mindfulness, resilience, shared experiences, and then just small group learning. What they noticed was that 3 months after the study, there was an increase in empowerment and engagement at work, as well as a decrease in depersonalization. And this change was sustained for 12 months, even after the intervention had ended. So 2 important things. 1, they paid physicians for their time at work, do something that was an investment in them. And 2, we're seeing results long after this intervention has concluded, which I would say indicate they were able to create, whether that's the system or a community within those physicians, those small physician groups, where people continue to see a benefit even after these purchase sessions. So let's take a closer look. As Dr. Jackson alluded to, we've acknowledged that women in medicine and those that are underrepresented in medicine experience higher levels of burnout. And in this study, they specifically targeted female resident physicians in an online group coaching program that lasted for 6 months. And they talked about reducing burnout, moral injury, increasing their self-compassion, and as well as imposter syndrome. And what they saw after this intervention was a reduction in emotional exhaustion and imposter syndrome scores, and an increase in self-compassion. So recognizing that even an online intervention that is not necessarily in person, that allows you to connect people who may be geographically distant from one another, we were still able to create that sense of community and provide these tools to actually impact their burnout, and especially in a group that we see higher levels of. And then the last is thinking about changing culture. Because as we know, where you work and the culture of that work environment affects your ability to do your job. And so in this study, what they looked at were the experiences of physicians when it came to mistreatment as well as discrimination for patients and their families. And they noted that 1 in 5 physicians respondents experienced a patient or a patient's family member who refused to allow them to provide care in the past year. And I would argue that having a patient or a patient's family member state that to you is pretty impactful, and it has an impact on your psyche. It has an impact on your own view of yourself, no matter how long you've been practicing. And what they saw were that female physicians and those that were racial and ethnic minorities had higher summative measures and discrimination, summative treatment and discrimination scores. So these underrepresented groups were experiencing not only higher levels of burnout, but they were also the ones who were most likely to experience treatment in addition to that. Now there's a direct relationship with the frequency of these remarks with emotional exhaustion, depersonalization, and burnout. So once again, highlighting the fact that we need to acknowledge that we need to not only ensure that we as physicians are creating a culture amongst one another, but that our system, our healthcare institution is creating a culture where our patients are treating us with respect as well, and that we're not being exposed to. And so we talked about studies that demonstrate what this could look like when you have money and time funding. So let's talk a little bit about just what that looks like on a day-to-day for us in our different roles. So thinking about the intensive care unit in particular, physicians that work in the ICU experience more than 50% of them experience burnout, not only because of the difficult patient situations they're dealing with, the difficult conversations, and also sometimes the ethical dilemmas that they're having to handle. And so practical communication training can be important in allowing them to not only provide that clear communication to patients, but also with other healthcare team members that they are helping to organize. Team-based interventions such as team debriefing, giving us all a chance to stop and process the things that are happening on a daily basis, recognizing that when a patient dies, we should pause. We should think about that. We should have a discussion as opposed to just continuing to see patients pretend like nothing has happened. Because we all know that when we do finally stop, it usually hits us all at once. And then also providing activities for provoke team bonding, recognizing that we thrive in a group or in a community setting, not so much when you're isolated. So this example is from family medicine. And some of us have already kind of talked about helping to offload some of those administrative tasks. And in this study, what they did was they were like, hey, what if we use medical assistants to take away some of those, not necessarily direct care, not direct patient care activities, but those minutia things that don't necessarily add to us as physicians, whether it's medication reconciliation, scheduling visits, and giving those tasks to medical assistants, they were able to see a decrease in burnout rate from 53% to 32%. So as was highlighted earlier in one of our discussion groups, recognizing that when you have other individuals to take on that load, you can actually spend more time with your patient. And then as a med chief physician, I had to include something on the inpatient side, because for me, wellness is a priority, and how am I able to incorporate that in my work? So having discharge rounds first thing in the morning where I can talk to social work, case management, identify my barriers and address them, so that way I can have my patients ready to go when they're medically stable. And then being able to easily contact other physicians. When you're working in a large hospital, sometimes it's hard to figure out which surgeon is on, who's on for orthopedics, how do I get in contact with them? So having a centralized directory that lets you know who's working each day makes it easy for you to pick up the phone and have a conversation with them. And then also just having nursing staff present when I'm talking to patients or when I'm making my plan for that day, because they see the patient more often than I am, and they'll be able to tell me when there's a case. So integrating them. So we'll do one more small group breakout. So we kind of talked quite a bit about organizational level interventions, well, things that you might see on a daily basis, and take a few minutes for you to think about something that you could change in your current work environment that would make your workday better. Essentially the question of what's the pebble in your shoe? What's the thing that makes your day a little bit more difficult? So we'll take a couple minutes. All right, we're gonna bring it back to the large group one more time. And if there is anyone that is willing to share any comments in their discussion, we would invite that down.
This one does. Anybody?
We've got a mic that works. Any brave volunteers? Well, I'm gonna take that as, oh, yes, we have one brave, thank you, thank you. Not gonna get it, there's a lot of water.
Fine.
Yeah, the grievance that I shared was click, 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 click. And I work in a federal system at the VA where changes are implemented and you show up that morning to work and, oh, things are different. And maybe you'll get an email later in the day explaining the new thing and all of the training you have to complete for it by the end of the week. One of the interventions was a change to our medication ordering system. So there are many more clicks and drop-down menus and explanations whenever we order medicines. And we learned that this is a process that started maybe 7 years ago. And because it was a national directive led by people who are not clinicians ordering the medications, it finally got rolled out. Now we're in the midst of a burnout crisis and these things just don't make sense anymore.
Yes, thank you for sharing that. I would argue many of us have click fatigue, so to speak, because you're constantly having to click the radio button to acknowledge what you've done. And if you don't, it will not let you move forward until you have clicked all said radio button. And I think you highlight a problem that we have seen multiple times, which is that those that are making these changes, especially when it comes to the electronic health record, don't necessarily understand what we as clinicians do on a daily basis. And so having clinicians at the table when they are definitely making changes can make sure that hopefully we don't encounter an issue where suddenly your workload has increased times 10, and not necessarily in a way that benefits the patient or anyone. So thanks for sharing. All right, so
she was talking about did you want? Okay, I was just going to say that we had spoken and she said that was a big barrier because she's working at the VA. She can't really implement any change as far as how their well-being. And the opposite, I was actually I just retired, but from a clinic where I worked for 26 years. It was physician owned. We were able to have more time with the patients at the cost of our reimbursement, of course. And we spent time together as a group in our office. Our retention rate is great. We have the people don't leave until they're retiring for the most part. And staff, everybody is always pretty happy. And we do the little get-togethers and talk to each other, and that does make such a difference on your day-to-day that even though you had a bad day, you talk to somebody else about it, you feel a little better. So
thank you for
saying.
sharing. So
it still exists.
it can happen. It can happen. So highlighting that when we invest in those that work around us and in our job to create a culture or environment where everyone feels seen and heard and valued, your workday is a lot smoother and easier. It's easy to debrief those difficult patient situations or difficult conversations. So now we're going to move to our last level, which is the individual level, which I would argue is probably the one you've heard the most about and feels a bit daunting because it's all everyone wants to talk about. So the first thing we'll talk about is mindfulness. So what is mindfulness? You've probably heard it like 10,000 times. You're like, I still don't understand what that means. So mindfulness feels very nebulous. So the definition is paying attention on purpose in the present moment, non-judgmentally to what's happening in the moment. So what it really means is that you're present in this room, listening to me talk, watching me slides. You're actually listening to the words that I'm saying. You're not thinking about the grocery list that you need to make, the task you didn't do because you decided to come to this conference that you need to do on Monday, or any of the other things that are in that like backlog that you're constantly thinking about. So you're actually present in this moment, listening to what I'm saying. And so we will skip this video in the interest of time, but it just helps to explain what mindfulness is further. So we'll now talk about another tool that you can use, which is resilience. You guys probably hear a lot about just be more resilient. You'll be fine. You're going to be great. And so there are ways to build resilience. One is self-care. And I would argue the most important part of self-care is first identifying what is not self-care. So you need to be able to know the things that do not bring you joy and then don't do them. So let's say that you hate basketball. If you just don't want to see a basketball ever in your life, but all your friends are going to the local NBA game, which for us is the Grizzlies. And so they're like, you should go, come on, it will be great. And like, oh, I guess I'll go. And then you have a horrible time. And you just wasted 3 hours. Don't do that. Don't do the things you don't enjoy. Instead, focus on the things that actually bring you joy, and those are the things that you should prioritize. And those are just examples of self-care ideas. And then the last is self-compassion. So we've all had a difficult patient encounter or a difficult patient outcome. And oftentimes that inner dialogue, when we reflect on what happened, is critical. It is not kind. Usually it's questions for things that we've done and our capacity and our ability to be efficient. But in reality, if we think about a friend who's had a similar situation, the words that we say to them are usually very encouraging. And we remind them of the fact that they are still a great clinician despite this encounter. And what we should be trying to do is have that more positive inner dialogue that is more compassionate as opposed to more critical. So I just highlighted these three different levels. I spent a lot of time on one of them in particular, so I might indicate which one I think is more important. And so I did want to talk about this study briefly that will be coming out in this month's edition of the Southern Medical Journal. And it talks about physician burnout in medically underserved areas during the COVID-19. And what they saw was that there was a high prevalence of burnout, despite high personal accomplishments, resilience, and mindfulness. So highlighting that no matter the presence of individual intervention, it's not enough to prevent burnout. And we should be approaching this at multiple levels. So harkening back on that quote about the canary in the coal mine, it's not just the canary we should be worried about, but it could also be the coal. And with that, I'll hand it back to Dr. Jackson.
Thank you, Dr. Burroughs-Ray. And so putting it all together, at the very beginning, we talked about this definition, interplay of emotional exhaustion, depersonalization, and the success of work-life integration, what some call work-life balance. And I mentioned also this idea of professional fulfillment. And for me, my hope in having this conversation is that it's not just getting towards the absence of burnout. That would be great. I think there are issues with actually attaining that, but also some sense of professional fulfillment. This is a model that's been out at Stanford for a while on professional fulfillment. And I think there are a couple interesting things. Two of those three things go beyond individual. So culture of wellness, efficiency of practice are not individual things. Those are system and organizational level things. The other thing I noticed is that there are no pizza parties or other small token things that are done in time, reflecting the fact that if we really want to move on burnout and wellness, it's going to take more. And part of what we wanted to do today by showing all the stuff on system and organizational levels is, for me, when I bring up issues at work, usually the response I get back is, well, Chris, fine. What should we do about it? And I'm like, well, I would love if you would come to the table with something to do, but if you must ask me what we should do, here's some data of things that have worked at the system, at the organizational level, so that you don't give me day old and tell me to be more well. And so why is it important that we change the coal mine? It's not just important for us. I would actually argue it's also important for the future of our profession. So they've looked at motivation and personality factors of Generation Z high school aspiring to study people. And again, third and fourth year high school students in Switzerland, I feel like this is probably still generalizing here as well. Those interested in studying human medicine have high intrinsic motivation, which makes sense. We have to have a high internal drive to want to give up most of your 20s to be able to practice medicine. But the other thing that comes out to me is work-life balance and job security. I applaud these high school students. I wasn't thinking of work-life balance when I was trying to get into med school or when I first came out into practice. I just wanted to get a job. They're thinking about this already. And so my argument is, if we all don't come together and try to figure out a way to dampen the onslaught of burnout and lack of wealth, we're going to lose these right and bottom line. So it's not only a problem of treatment, it's also a problem of prevention and making sure that this generation can practice this medicine the way that we think it should be practiced. These are our references. And with that, we always like to end presentations with photos, of course, I'll let Dr. Burroughs-Ray share her photo. This is a photo of me and my wonderful wife, 15 plus years.
And then this is my little family. That's Peppa on the far left. She got me through residency and then becoming an attending. And then Emery, she's 9 months old and the giver of this wonderful gift I currently have. And my husband, Nick.